Thank you for joining our webinar, Obesity, Stigma, and Weight Bias, Understanding the Disease. We're so happy to be able to present this information and feature our speaker today, Dr. Valerie O'Hara, a pediatrician and childhood obesity expert.
Great. Thank you, Carrie, and thank you to everyone who's taking time out of their busy schedule today to join us. So weight bias, stigma, we're going to talk about this by understanding obesity as a disease. So what are weight stigma and weight bias? So by definition, it's an unfair and negative devaluation, prejudice, or discrimination about or against an individual or group based on their body weight or size. So weight stigma specifically is social devaluation of a person due to body size based on negative, unfair beliefs, mindsets, and attitudes. Weight bias is a distorted treatment and outcomes lacking objectivity in actions, policies, or decisions. And we know that unfortunately patients living with obesity experience many negative stereotypes. We see here they're oftentimes associated with terms like lazy, unmotivated, lacking self-discipline. This is really representing some prejudice that exists, that preconceived negative judgment about people based on their size, and ultimately some discrimination and unfair treatment due to body size. In terms of types of bias, we know there is explicit, which is intentional or conscious, and implicit, which is unintentional or unconscious. We know there's public. It also translates into our associations in terms of social units. And for our children, it's family, school, and work. But more importantly, we think about internalized bias, that which our patients feel towards themselves, and that negative impact on their interpersonal relationships. And children who experience bullying and teasing by their family were more likely to have significant internalized bias and carry that forward with them. We know that youth with obesity are more likely to be bullied than their thinner peers. Here's some statistics. Weight most frequently is the source of bullying for up to 40% of children. 95% of adolescents have observed teasing and bullying towards their peers. When I ask patients, maybe sometimes the easiest way to have that conversation at first is saying, have you ever witnessed bullying and teasing at school or home or otherwhere? And they'll say, yeah, I've seen it, or maybe I've experienced it. So it's a nice way to lead into that question. For youth who are engaged in obesity management, 90% shared experiences of teasing and bullying by their peers. The most common reasons for bullying, we can see here, this was looking at 4 different countries across different reasons for bullying. And we could see on the left here that being overweight far exceeds the reason for bullying compared to sexual orientation, ethnicity, religion, family income, physical disabilities, and others. So how does weight stigma impact health? And we know stress has a lot of negative impacts on our eating and physical activity behaviors, as well as our physiological reactivity. From a healthcare quality, patients who are living with obesity experience poorer treatment adherence, less trust of their healthcare providers, avoidance of follow-up care, and delay in prevention of healthcare screenings ultimately. And if we take this collectively, we know this can worsen obesity. We know that it worsens psychological distress. It can create or worsen existing anxiety and depression. And from a physiological health perspective, we know patients with obesity experience lower overall health-related quality of life. And we see this even in our adolescents. So how do we acknowledge the complex etiology of obesity? We can understand there's physiology here. Then we can move past this first square where this is all about individual choices and behaviors. That increases stereotyping and stigma for people with higher body weights or with obesity. So if we change that narrative and we start with the premise that there's genetic and biological underpinnings along with the environmental, societal, psychological, and behavioral factors together, we can hopefully reduce weight stigma because we're improving the understanding of the complex etiology. So we know our body has many, many homeostasis mechanisms set in place to control our body functions, whether it's our blood pressure, our electrolyte balance. This is happening at the subconscious level. And the same is true that the body seeks a stable fat mass, just as other regulated tissues do. With that, we also know that obesity is a highly heritable chronic disease. And we know that heredity plays a 40 to 70% dominant role in the risk of obesity. So I think this triangle in this perspective is a little bit different than that prior narrative where we were looking at this as personal choices or all about just about the environment. We know that there's this biology, genetic risk with the environment and personal choices on top of that. So I often start And I share this visual with my patients and families. The energy regulatory system physiology oftentimes drives the behavior rather than behavior driving the physiology. And I say there's three parts of our brain that we're thinking about when we talk about the energy regulatory system. We have our cognitive thinking brain, where we're learning about healthy foods and portions and my plate. Then we have our metabolic brain, where it's getting nutrient sensing hormones that are coming up to the hypothalamus and from the periphery that are informing the brain about what are our energy stores. And on top of all of that, we have the hedonic or reward center of the brain that is looking at the salience of food. It smells good, tastes good, I want that. And all of this is all talking, cross-talking to help inform us about our energy storage and whether or not we need to take in energy or feel full. So we have that physiology here introducing into this our obesogenic environment. Treatment of obesity requires our attempts to best focus on those pathways and re-regulate that physiology or that fat mass set point. So if we use our old adage, just eat less and move more, and when we overly restrict calorie intake and increase physical activity alone without addressing that physiology that is dysregulated, we may lose weight, but then our body is sensing that change. And what do we see? We see the satiety hormones go down, hunger hormones go up, our metabolism slows, and weight regain occurs. We also know that there are critical periods of development where obesity may occur. What's causing that dysregulation is different across the lifespan and for different patients. And particularly for pediatrics, we know there's times of risk. Maybe it's prenatal and infancy, early childhood. And again, during adolescence, the impact of puberty, we know, can be a time of that dysregulation. And when that occurs, it's high risk to persist into adulthood without intervention. And we know obesity impacts all the body systems. In the adult literature, up to over 200 complications may be obesity related. With worsening obesity prevalence, we have seen these occur even in our youngest of children. So I want to switch gears a little bit as we think about bias and stigma, the words that we're using, the words that our patients are using. So one of my former patients shared an early letter, and these are his words. Obesity has been a problem that has plagued my life for many years. Before, I had tried several different methods of weight loss. While these diets and programs provided temporary success, they ultimately ended in a return to my old eating and exercise habits. Since I started the program, however, this has drastically changed. I also discovered that I have sleep apnea. I was able to get a CPAP machine to treat this affliction. They look at every possible factor that could be contributing to a patient's weight. There are many other children and families with the same or similar weight problems that I have. If they had access, their lives would be changed for the greater. And this patient's mother also shared her perspective. He has struggled with being overweight most of his life. His self-esteem related to his weight was at an all-time low. He would often joke that he would be lucky to live to be 30. I knew he was afraid of what the future held for him. Not only was he afraid of the future, he was struggling with the present. As his mother, I was feeling shame, grief, and worry. I felt like I had failed him. From the very first meeting, the staff made us feel at home. It has also given us strategies, knowledge, options, and ideas. As his mother, I no longer worry if he will lose weight. I know that he will. He will be a highly productive citizen and will make the world a better place. Powerful words to think about. The American Academy of Pediatrics provided this clinical practice guideline addressing the key takeaways that obesity is a complex chronic disease, and the comprehensive whole child evaluations are vitally important. We need to be treating obesity along with those comorbidities, and children with overweight or obesity should be offered treatment upon diagnosis. No more watchful waiting. Because we know what happens when we do not treat childhood obesity, and we now have significant data in the adolescent and childhood population. All of this comes to a head when we think about quality of life, those social issues that lead to lower quality of life for our children. So the major challenges to effective obesity care, really, we need to look at perceptions that obesity is not a disease. When we think about obesity-related prejudice and stigma, there's discouragement for patients seeking care. There's stigma against providers, limited availability and reimbursement, and barriers to the development of new novel therapies as well. In spite of all of those things, this is still an exciting time. We're improving the number of effective tools and combinations, and we're learning so much. So our key messages for patients and family is obesity is not your fault. Obesity is a heterogeneous disease. We need to treat obesity like any other chronic disease, connecting to a patient, offering treatments that can make a difference. And when a treatment doesn't improve the disease, the treatment failed, not the patient.
Thank you for joining us for session 2 in our webinar series, Living with Obesity, the landscape for obesity care experiences for children and families. I'm so glad we're able to present this information today to you all and feature Liz Paul as our speaker. Liz is a board member of the Obesity Action Coalition and serves on the membership and mental health committees. She uses her first-person experience to advocate against weight bias and stigma and for access for obesity treatments for all people. I'm so glad she's here with us today to present, and I will turn it over to you now, Liz.
Thank you so much. I'm delighted to be here. I'm going to start sharing my screen. We're going to jump right in. I do have some disclosures there. I've spoken with a lot of different places, and we want to acknowledge the funding for these wonderful webinars, which I get to be a part of. So we are going to talk a little bit about weight bias and stigma in treating children and families with obesity, and the internalized bias that we all may experience, and how they may create barriers to treating children and families. So before we get into that, a little bit about me. I have lived with obesity my whole life. I grew up in a larger body, and I am a parent of 2 beautiful children who also struggle with obesity. And the thing I remember about being a child living in a larger body is that the messages I received, both from my mother, my family, and society at large, was that my weight was my problem. And it was my problem to fix. And it was my problem that somehow I had created. And not only that, somehow I was the problem. And that really stayed with me my whole life. And it wasn't until much, much later in life that I realized that obesity is a disease, and it's not my fault, but it's my responsibility. And that is a different message, because if it's my responsibility, I'm allowed to ask for help and use tools and treatments available to me. There's a lot of stigma and bias associated with it. When we pay attention to what we tell ourselves about weight, eating, and size, these are learned behaviors. We aren't born with those opinions about our bodies. And internalized bias and stigma, they can lead to our negative self-worth, and they can cause us to stigmatize others. And they can prevent us from seeking care and support because we may feel as we don't deserve it. And I include this because regardless of our size, internalized weight bias is something we can have. They can lead to very serious mental and physical health outcomes. So as we look at these consequences from a psychosocial standpoint, they can range from lower peer acceptance all the way down to depression, anxiety, and suicidality. In addition, there are biological consequences from elevated stress hormones, and cardiovascular risk, all the way to worse health outcomes and quality of life. These are not meaningless things. Bias has very serious health outcomes for patients. So, overcoming internalized bias means that we have to pay attention to our self-talk. We have to catch it, we have to check it, and we have to change it and replace that negative thinking with neutral or positive language instead. But there are action steps we can do. So the first thing we have to do is we have to take some time to self-reflect and say, what assumptions do we make about people with obesity? Do we stereotype a person's character or personality? How do you feel when you interact with a person with obesity? And are you sensitive to their needs and struggles? Critical in all of this is how to be a good ally for children and families. And I use the word ally because you really are needed to be a partner for children and families. Each patient is going to be in a different place mentally and physically when it comes to their treatment. So shared decision making is always going to be key for trust in this situation. Not every patient is going to be ready to jump in to treatment, and forcing an issue isn't going to get them there any faster. We have to seek to eliminate covert bias in clinical settings. Do you actively listen to children and families and the language they use around their weight and their body? We need to share realities of obesity as a disease in age-appropriate ways and share that it is not a lack of willpower or a moral failing. And we need to try to not make the focus of their visit on weight, which is a symptom of obesity, but on health. And that may mean that weigh-ins are not always clinically necessary. We need to help patients set realistic goals and celebrate their wins, including non-scale victories. And we need to recognize that obesity doesn't live in a vacuum, and compassionate care and support of neurodiversities, mental illnesses, and other concerns may take a top priority. Here I want to tell you just a brief story about my son. Now, before I knew obesity was a disease, I did not realize me being told obesity was my problem to fix was wrong. I thought that was normal because it was my problem to fix, I believed. When my son was 12, we went to the doctor. Keep in mind, this was during COVID. Now, my 12-year-old was depressed. He was doing school from home, and he was struggling to get his work done because of his neurodiversity. And his pediatrician at the time only wanted to talk about his weight. And it was a very stigmatizing visit for us. He looked him up and said, you know, if we look at your chart and if you gain as much weight as you did this year, you're going to be 500 pounds when you graduate high school. And that was the last thing he needed to hear. So I encourage you to remember that while obesity is a serious problem and we need to address it in children early and often, it does not mean it has to be the top priority all the time. The other thing I encourage you to remember is that for kids who have neurodiversities, there are going to be food sensitivities and other issues. So working with dietitians who know about food sensitivities and neurodiversities are going to be highly important. It's also important, as we talk about things, to be a good ally for parents. Parents are coming at this too with a lot of shame and blame. They blame themselves for their children's health. So please be a good ally for parents. Don't blame them for their own obesity or for their children's obesity. Please ask lots of questions and acknowledge that they're the expert when it comes to their child. And take the time to explain the realities of obesity as a disease. And please ask what treatment options are financially feasible. It's important as we know to know the landscape of obesity treatments for children and youth. It is ever changing, as we know. Intensive behavioral and lifestyle treatment and family healthy weight programs are great options for many kids to start addressing obesity. It's always a good place to start. And finally, I encourage you to know what you don't know. So make sure you ask for help if you think you have a child that may benefit from obesity specialists, so you can get them additional support and knowledge of potential treatments when needed. Beyond that, there are opportunities to take action outside of your practice. I work with the Obesity Action Coalition. We are a patient group, but we have many physicians who are also part of our organization. And we have ways to advocate for policy changes, as well as ways to report bias and to share your story. Bottom line is bias-free care must become the standard for patients and families living with obesity. So we don't want children and families to manage this alone. People need access to affordable tools and treatment. We want to be able to provide that without shame and blame in a bias-free way.
Thank you everyone for joining us today for session 3 in our webinar series, Putting It All Together, how to talk to families and patients in a supportive environment. And I'm so glad that we're able to feature Dr. Valerie O'Hara as our speaker, and I will turn it over to her now.
Awesome. Thanks, Carrie. And thank you all for taking this time to join us in our third in our series here. So we'll get started with thinking about a framework of how we talk with patients about any diagnosis. So the 5 A's is a model for behavioral intervention strategies, and it's been adapted for obesity management. So it starts off with ask. We're going to ask for permission to discuss growth trajectory or obesity, or I tend not to use the word weight because I think that's a vital sign. And then once we've gone through that stage, we can assess. We take your blood pressure, we're going to stage that 1, 2, or 3. And that then helps us guide our future discussions around this diagnosis with our families. And then once we've been able to gather that information, I call it my fact-finding mission, we can use all of that to then advise, right? Offer the opportunity to explain benefits of weight management or obesity care, and explain these for short and long-term strategies, because we know, as we've talked over our sessions, that obesity is a chronic disease. And then we can agree on realistic goals and expectations, things that they can work on, come up with a shared decision-making plan, right? Again, awareness of what's out there, sharing the data when families and patients are ready to hear that. And then once we've come up with a plan, we need to assist with education, tools, resources that we might share, and we're going to arrange that follow-up. The Red Center also shares some strategies that can help facilitate a supportive communication, right? Looking at active and reflective listening. And the next few slides, we'll kind of break these down a little bit as well. Using sensitive and respectful language. Acknowledging patients' prior experience. I remember the adolescent that I talked about in our first webinar. He shared in his podcast with medical students to acknowledge prior experiences and treatment endeavors that they've engaged in. Oftentimes he shared that the new healthcare provider didn't acknowledge what he'd already been doing that were already very healthy habits. And then focusing on those health behaviors and not weight, treating this like a disease, and then engaging in collaborative goal setting because it's a shared decision-making process. The Red Center also shares this idea of using the ORS approach, which is using open-ended questions. Can you tell me more about that? How do you feel about this diagnosis, your healthcare, your goals, right? How does that make you feel? Affirmative statements. I can understand why you feel this way. Thank you for your willingness to share and discuss this with me. I use that last one a lot. Reflective listening. It sounds like you feel XYZ, so bringing that back. And then with reflective summaries to really come back. So what I'm hearing you say is X, Y, Z, making sure we're understanding each other. So that active listening and reflective listening can help us alleviate patients' anxiety and fear. We know it can promote patient engagement and building that trust, and then making sure they feel validated and heard and understood, right? And this also offers the opportunity for clarifying expectations or misconceptions, making sure we're hearing each other because we're working in that shared decision-making process. In terms of respectful terminology about weight, the Red Center has shared this data and was published in 2021 and 2020. And overall, the words about weight, it can be very sensitive. But overall, in the publications, the preferred terminology that stands out is weight, high body weight, or unhealthy weight. Again, this is very individualized. So starting with the first of the 5 A's, which is asking permission, can we talk about your growth today or your health around weight? And if they say yes, then you can say, you know what? Obesity is a diagnosis. It's in the EMR, but I want to know what words you feel most comfortable when we're talking about this diagnosis. And then you go ahead and use that term. If they say, no, I'm not comfortable, acknowledge that, validate that, say it's okay. And so putting it out there that I'm here for you when you're feeling ready. So in this slide, it's really the initial outreach in a clinical application. This was from my prior nurse clinical coordinator. So when we were getting patients referred to us, the first thing she would do is reach out to the parent, answer their questions, and really meeting the patient and parent in that moment when she would call was really, really informative, helpful, and then patients know what they're walking into and feel ready to come. Validating what has their prior experience been with healthcare providers, or even with their parents, maybe if you're talking to the patient, really assessing how they are describing obesity, how to review prior treatments that they've already tried. So taking the time to listen, as that is focused, voluntary, and intentional. So we want to validate that we're hearing them and we're listening to them. And when we do that, we can provide empathy. So the next steps, once we've had that, right, we're building on that rapport and always keeping the why first. And this can increase our parent receptiveness and readiness to engage in those conversations. And then addressing myths and also being aware of cultural beliefs and letting the patient and parents share. And being aware that we're listening for signs of prior bias, but we're also reading that body language from the patient. And we can do that even during a Zoom visit for sure. And we're making sure that, again, to quote that very wise teenager at the time, if you're going to talk about this, be accurate, make sure your information comes from the heart and actually reflects the complexity of the disease of obesity. So when we do that, then we can start to share a comprehensive expert approach to medical care for this diagnosis. And this highlights you are treating obesity like any other disease. So patients' words and their experiences is certainly what we want to think about and want to use. And so in this paper that was published in 2017 in the AP statements, again, their findings underscore the diversity of youth preferences, right, and the need for individualized approach. Terms that patients preferred were weight, normal weight, healthy weight, and some ethnicities preferred curvy and thick. So the best way to know is to ask. More recently, Dr. Poole was presenting, and she was sharing additional data that came out and that they published in 2023 that negative comments from parents showed worse adolescent health and well-being in terms of greater depressive symptoms, higher internalized weight bias, more unhealthy weight control behaviors, and poorer body image. Versus positive comments from parents showed improved adolescent outcomes. And these findings were consistent across all of the adolescent sociodemographic characteristics, and regardless of whether this was coming from their mom or their dad. Additionally, in her presentation from that same paper, parents want guidance on how to communicate about this diagnosis. And so they're coming to us as their healthcare providers to provide that guidance. And most parents want information and resources for strategies that can help. So improving their child's body image and self-esteem is vitally important. Supporting their child in making healthy choices for long-term health and focusing on health rather than weight. And helping their child feel supported with their size, and particularly for children who are being bullied and teased, and how can we help them? We know that, unfortunately, in healthcare, have certainly been found to attribute the causes of obesity to controllable factors such as lack of self-control, laziness, and lifestyle choices or overeating, and that parents are blamed for their child's weight. Many times parents are viewed as personally responsible as a failure for their child's weight, even when their parenting practices that they were describing were aligned very well with the AP guidelines. So what do we do in our environment, and how do we make this better for us and our patients? So key points: the environment that the patient encounters improves care. We have a big sign that says, "Welcome, we're glad you're here." And they need to feel that from the moment they walk in the front door of your office. We want to share that we're listening to them. And when we do that, we can build our trust over the next few visits, right? And ultimately, the goal of the first encounter, or if you're the primary care doctor, first conversation that you might be having about the diagnosis of obesity will lead to the second. And in 2017, the expert panel found that the decisive factor in obesity care was not what sort of diet the patient went on, but how much attention and support they received while they were engaging in whatever therapy that you all devised together as a family and clinician. So when we're thinking about all of this, what does this teach us? It's really asking us to think about the team approach. And then we can share those treatment options with the same level of medical data as we do with any other diagnosis. And when we do that, we can ensure ongoing monitoring for response. And remembering to leverage your expertise as the primary care provider or any of the pediatric clinicians who are working with your families, right? You have that mastery, you have those skills of having really sensitive conversations on a host of medical topics, and coming in there and being compassionate and taking the time to listen and validate. It goes a long way of building that trust for our patients. And I'd like to close with an important quote from a teenage patient of ours, and these are his words. If you give advice, make sure it's accurate, it comes from the heart, and reflects the complexity of the disease of obesity. Thank you so much, and I look forward to further conversations and discussions in the future.